Hello, and welcome to the Health and Care Across Life course theme. My name is Dr. Pallavi Deshpande, and I'm the new theme manager. Today, we'll be taking you through some of our activities over the last few months, and these will be presented in the form of pre-recorded presentations. After the presentations, we'll be moving into breakout rooms, which will be in a World Cafe format. Here you'll be given the opportunity to provide feedback, to discuss, and even vote on areas of prioritization and offers for collaboration. With respect to other activities within the theme, we continue to progress with our Serious Illness Conversations project. And social prescribing is now a cross-theme program with wider national ARC engagement. I hope you enjoy the session. Thank you.
Welcome to our Health and Care Across the Life course theme update. I'm Mark Gabay, I'm the theme lead and I'm a GP in Liverpool. So I'm going to briefly tell you about where we're up to with our COVID research that we've been supporting across the theme. One of the big projects that's been happening locally at least has been the COVID Live study. And we've been providing the research for the social science elements of that. So this is split into various components, and I'm going to particularly concentrate on what's called COVID Live A and COVID Live B. COVID Live A is a longitudinal household survey of 290 households in particularly poorer areas of Liverpool. That's just completing its data collection at the end of 3 months. We've also been doing some work that Clarissa's going to talk about and has talked about before, about looking at the impact on people living with dementia and the frail elderly and their carers with a loss of social support through the pandemic. And that work is now being replicated in Australia, Poland, Italy, and India. A number of papers have come out of that already. This is having a lot of impact both nationally and beyond. In terms of COVID Live B, which is the one that I'm leading, this is more of a qualitative focus on how people perceive the risk of the pandemic and their responses to it. So we've been dipping in detail to a purposive sample of households from COVID Live A. We're also looking at what's been happening in the community in terms of community activists and organizations, and what's happened to what they used to be doing in the community since the pandemic started. And we've been working with and talking to local employers about their response to the pandemic and risk to themselves, their staff and their customers, if that's relevant. A link to that is work we've been doing with colleagues in Malawi, Cameroon and Uganda, looking at these aspects to people living in these countries as a result of the pandemic. And also more locally, Dr. Hassan has been working with the Muslim community, doing focus groups and individual interviews to see how they have been managing risk within that community. And those papers are now being written, that data collection's completed. We're now looking at working with the university to support the the evaluation of the mass testing that's going on. And this is work that's just underway. Next slide, please. We're also looking at what happens after COVID. So we are involved in discussions about a number of grant applications about long COVID, working with colleagues at the UCL in London, Birmingham, Hull, for example, on that, as well as a local project with colleagues in Liverpool at the moment, looking at rehabilitation for recovery after COVID through exercise. And how an app may help that as part of that as well. And this may well link in with the large London project, which is looking at the overall structure of shared care and how primary care is going to be supported in managing people with long COVID. We've also been looking at, we have with our Seaside Town network that you've heard about here previously, they're particularly interested in what the long life is of their community hubs that they set up around COVID and what may be the future for those and that fantastic community volunteering that's been going on as the pandemic hopefully fades away. What could they start to focus that energy into in terms of maintaining and improving the health and well-being of those communities? And that links with another area of work we're looking at, which is longer term community-focused work and support for people with mental health issues following the pandemic.
So I'm going to share a bit of an update on our COVID-19 and care homes work. So last time at the theme meeting, I was sharing some work on our community-based COVID dementia and social care study. And since then, we've been awarded some extra funding to look specific applications of the public health measures on family carers and care home staff in the UK. So, as we all know from the news, care homes have been really badly affected by the pandemic. Over half of the deaths recorded have taken place in care homes. And what we wanted to understand qualitatively is the experiences of family members who have a loved one with dementia living in a care home across the UK. And about their visitation rights, their emotional impact, and how they feel that their relatives are experiencing the pandemic and the inability to see them. But we also wanted to understand this from a different point of view. So we also wanted to speak to care home staff across different care homes across the UK and understand how care provision has changed throughout the pandemic, including PPE measures, for example, regular testing, and then to understand from their point of view as well how they think that residents are faring throughout the pandemic, because they're seeing them every day, and have they noticed any changes in their engagement, well-being, for example. So we've started data collection 5 weeks ago, and we are wrapping up this study in the next couple of days. The aim was to speak to around 20 family carers, or unpaid carers as we say, and around 20 care home staff. We have now spoken to around 40 people. We've got still one more to talk to. And I believe because it's so topical at the moment and it's impacting on so many people's lives, we sadly had to turn away quite a large number of family carers. They wanted to take part, we were already over-recruited, but what we found so far, so we've not started fully analysing the data yet, but having done some interviews myself, and my colleague has done most of the interviews over the phone, was that really varied experiences, including between different care home providers and care home staff. So we also looked at end-of-life care measures, obviously, because we're exploring the care homes. And one quote, which I think was incredibly tear-provoking for me when I read the transcript as well, was so a carer wanted to see her mother, but she had received an email from the care home saying, "You will be permitted to see your mother when it is deemed that she is dying." Now, where's the well-being and care for the family member and care for the resident there? So there's clearly, I don't know, it seems there's not much care provided by the care home in this instance, but we've also spoken to a number of care homes, and it's interesting to see how each care home is implementing the guidelines differently. Some are having visitation pods, for example, some are having window visits, some are having none of that. And there's a couple of more quotes which you can see, and overall, obviously, it's become so much harder to care for people. And one thing that was noticed throughout the interviews so far that we've done was that wearing face masks for care home staff is really difficult for residents, particularly those with dementia, because they can't recognize the care home staff and they don't see the facial expressions very well. So there's this almost separation in the relationship that care home staff used to have with residents. And now I'm handing over to Rosie, who will share some information about her Me to You centre.
Hello everyone, my name's Rosie. I'm a registered mental health nurse and the clinical lead, director and founder of the Me to You Day Centre. Next slide, please. A little bit about the Me to You Centre. What do we do? Our core services run similar to other day centres, as in we provide a home-from-home day centre that's full of kindness, with a home-cooked meal, lots of activities, including singing for the brain, an intergenerational choir, pool room, a bar, a bistro, etc. The people we support don't get told they're going to a day centre. They believe they're visiting our cafe, our allotment, a knitting at a group, footy fan club, so on and so forth. They get involved in the things that's familiar to them so that their carers know their loved one is relaxed and safe. Next slide, please. What do we do different to other day centres? Well, to name a few, we're very flexible. We offer post-diagnostic support, and that's based on listening to the needs of the carers and the person living with dementia. We offer rehabilitation and stimulation. This involves activities of daily living, gardening, music therapy. We have a man shed. Carers are welcome in our centre and they have access to our crisis line 24/7. We offer personalised transport to suit the client and the carer's routine. We are CQC registered for domiciliary care, and that is specifically for the clients who attend our centre, ensuring continuity of care. We have future plans for the Green Care Farm, a model of care like in the Netherlands, and we're currently testing this small scale as we have chickens, raised bedded allotments, and other small pets. Thank you.
Good morning. I'm Dr. Sujit Jadekar. I'm consultant psychiatrist in learning disabilities. I work for Cheshire and Wirral Partnership NHS Foundation Trust. I'm going to talk about Dst Physical Health. This is a project we are doing in CWP, and I want you to give a bit of background information, but also think of the next steps, especially the research component of this tool. So you all are familiar with LEDER report. This is a review of mortality in people with learning disabilities. The project is going on for last 5 years or so, led by Bristol University, and it produces a report every year and makes recommendations in terms of local implementation to reduce the risk of preventable deaths in people with learning disabilities. We wanted to consider a population health management based approach to implement some of the LEDER recommendations, and that's how this current project has come about. We thought that having a tool to identify or proactively identify those who were at risk of premature mortality or preventable death will allow us to provide some targeted systemic proactive solutions in order to actually manage some of the risk of preventable death in this population. You all probably are familiar with the risk stratification process. It is a cornerstone of population health management principles. It allows those targeted interventions by identifying the group for those targeted interventions, but such approach requires good predictive accuracy and hence the research component. The development of the tool process has been quite robust. So obviously we took into account all the factors that were coming out of LEDER review, for example, causes of death, indicators of poor quality, etc. We looked at the recommendations by local reviewers. We carried out a systematic review of literature. It is now given for publication. We did focus groups, Delphi groups, and then we rolled out the tool in CWP services to get feedback on utility, and based on that we have improved on the tool. It can be used in primary care as well as in secondary care. I have presented the tool at our CGP event, and there was a lot of interest from GPs to use such tool in their services. It is based on the individual's current presentation. Obviously, it requires regular review if that person's circumstances or underlying conditions. The tool has two parts. Part one is about factors impacting on physical health outcomes. So it will take into account things like level of learning disability, presence of autism, etc. Part two is about underlying health conditions. All the variables are weighted based on the scores. It generates RAG rating, and then there is an overall RAG rating based on part one and part two. RAG rating has a clinical meaning. So rates are those who are at imminent risk of premature mortality or preventable death. Ambers are at high risk of premature mortality or preventable death. But we consider that everyone with learning disability has some risk of premature mortality and preventable death if reasonable adjustments or annual health checks are not in place. Based on the RAG rating, we have a response framework. This has been rolled out in our community learning disabilities teams. I'm not going to go through details of that at this stage, but it takes into account things like healthcare coordination as recommended by LEDA reviews. What does this allow us to do? It is quite quick to use both in primary and secondary care. It takes into account all the potential risk factors. It objectively identifies level of risk. It does allow for focused interventions, both at system and at individual level. But we think that it will allow us development of more innovative solutions as it is rolled out in wider services or as it is used more widely, and it will inform commissioning intention. It does fit with NHS long-term plan. We are looking at service innovation. We are looking at health inequalities here. We are also looking at actually using digital technology and data. From that point of view, it fits quite well with NHS long-term plan. So from a research point of view, there are 3 steps that we want to consider. First is the tool validation in terms of its reliability and validity, both in primary care and in secondary care. Then we also side by side want to work on development of a model of care in partnership with primary care, secondary care, and service users carers, and then start thinking about outcomes evaluation. In terms of outcome evaluation, it's the short and medium term outcome as well as longer term outcomes that we want to consider, especially as we start rolling it out and developing models of care. And this is where your input or help is going to be very, very important, both for validation and for outcomes evaluation.
Hi everybody, it's Rhiannon here. In this brief presentation, I want to try to whet people's appetites to become involved in developing a funding application that will allow us to harness the power in our communities to tackle mental health and wellbeing challenges during COVID recovery and post-COVID. And I want to start showing you some figures which really emphasise the importance of mental health as a challenge during this time, using some local figures and then comparing them to some national figures. So between the 15th of June and the 31st of August this year, we ran a COVID household survey in the Liverpool City region. That was wave 1 of that survey, where we collected 290 participants. And what we found was that 27% of this sample scored moderately to severely depressed, and 36% of the sample scored moderately to severely anxious. Now, according to ONS data, 19.2% of a UK sample reported some form of depression during the pandemic, rising from 9.7% pre-pandemic. And between the 30th of April and the 10th of May this year, 37% of the UK sample reported a high level of anxiety. So we can see there that our local data in terms of anxiety is pretty consistent with the national data, but it seems that the people in the Liverpool City region are feeling more depressed perhaps than the UK sample as a whole. Now, we all know that really good stuff is going on in our North West Coast communities to support those most in need during the pandemic. And this slide shows just a few examples of those activities. We also know that purposeful activity like volunteering and being involved in community groups is good for both individual and also for community well-being. And so what I'm proposing is that we should study the effects of these activities on community organisation members and on volunteers, and that we should then be trying to harness and build on the momentum to support community wellbeing in the North West Coast, and do this via continuing the support for those experiencing low wellbeing post-COVID, and perhaps in particular focusing on a small group of people who are suffering from what's now known as long COVID, where we know that mental health continues to be one of the challenges that they face. And so I'm offering here just a few ideas of the kind of things that we might do. So we might scope out the good stuff that happened in our communities during COVID, and we might try to understand the community wellbeing benefits that resulted from those activities. We could spend some time exploring ways of sustaining what turns out to be the best stuff that happened in our North West Coast communities. And in doing that, we might attempt to link into social prescribing models that are running in our area, and to link up more closely with community interest companies and with the communities themselves in order to better understand how those activities can be delivered and sustained. And maybe perhaps we could develop a toolkit and a North West Coast model for really building back better for the benefits of people who live in our area.